My name is Dr. Robert Derlet. I'm a professor of emergency medicine at the UC Davis School of Medicine. Today I will be discussing pathogen detection in the emergency department and evidence-directed treatment. Our learning objectives today are as follows. 1. To understand the current diagnostic and treatment challenges in the emergency department as it relates to evidence-based medicine for infectious diseases. 2. To learn about the infectious disease diagnostic needs in the emergency department and to devise a modular point-of-care testing platform for the acute care and emergency department settings. 3. To understand the utility and value of point-of-care testing for pathogen detection in the emergency department. This will be heavily weighed on my experience of 30 years in the emergency department and will give you the perspective of an emergency physician on the front line facing dozens of patients each day who need care for infectious diseases. The outline for today's lecture is as follows. First, I'd like to discuss problems in the emergency department setting related to overall care of patients. 2, I'd like to review some specific diseases that are challenges to us in the emergency department. 3, to review current diagnostic measures. And 4, to discuss how point-of-care testing will improve care in the emergency department and acute care settings. Emergency department problems with infections are multifactorial. First of all, most emergency departments in the United States and throughout the world are crowded. Secondly, infections are time dependent. Third, undifferentiated diseases and infections are common in the emergency department. For example, 20% of patients with pneumonia present not with fever and cough, but simply as weakness. Finally, patients may have acquired diseases from around the globe just within the past 24 hours and then present to emergency departments. Fever in itself is non-specific and not sensitive. Many infections may present without fever, with only weakness and malaise. There are some non-infectious sources of fever which may confuse things in the emergency department. And finally, electronic instruments, most commonly the tympanic membrane thermometer, are inaccurate in many cases in the emergency department. Let's start with the way patients present to the emergency department. The triage nurse is charged with the initial evaluation of a patient with the sole responsibility of determining which patients are sickest and need to be seen the soonest. As such, the triage nurses are exposed potentially to many infectious diseases. This is a very difficult job to sort out which patients are sicker than others when the average triage nurse may spend only 3 to 5 minutes with each patient. After patients are triaged, they are sent to wait in the waiting room if they do not require immediate critical care. Some patients wait in emergency department waiting rooms for 6 hours before being seen by a physician. In extreme cases, some patients may wait up to 24 hours in crowded emergency departments. As you can see from the illustration, the spread of infectious diseases can be rampant in a patient who has a highly infectious disease and sits in an emergency department waiting room for 24 hours, infecting multiple other persons. Diseases can progress rapidly. This is a case of meningococcemia, which may have presented as a minor rash when first seen at triage and not identified as an infection, and therefore the infection could progress while the patient was sitting in the waiting room. This brings us to the concept of the golden hour. Delays in appropriate antimicrobials may result in disability or death. The sooner the antimicrobial is administered, the better. There have been multiple publications that have examined this concept for many diseases, including meningitis, pneumonia, and sepsis. There has been much litigation on delays in the administration of antibiotics in septic patients, and it has clearly been established that the sooner antibiotics are administered, the better outcomes of patients who present with symptoms of sepsis. One of the most frustrating dilemmas in the emergency department is being unable to specifically diagnose a patient who has an infection. Numerous times throughout my 30 years, I've said, "I have bad news for you. I do not know what is causing your fever and cough." Physicians are then almost forced through patient pressure to prescribe an antibiotic, many times inappropriately. The current treatment of infections in the emergency department, in many cases, is an educated guess and choice of antibiotics empirically. What we really need in the emergency department is knowledge of a specific pathogen in order to use goal-directed and evidence-based therapy. Studies have been done examining the use of empiric antibiotics in emergency department settings. It has been noted that there is variability among the physicians. In addition, excessive antibiotics are prescribed, and at times the wrong antibiotics are prescribed, antibiotics that would not be effective against the pathogen that the patient actually has. Emergency department care is compounded by the globalization that has occurred over the past 20 years. Patients may be acutely ill in a country 12,000 miles away and board a plane and within 24 hours show up in an emergency department in New York City, Los Angeles, or Chicago, potentially infecting hundreds of other patients. It is estimated that 1 billion people travel by air each year. Some of these travelers may have diseases which are highly infectious, including influenza, tuberculosis, adenovirus, RSV, SARS. We know that infections that are spread by small droplets, or as referred to previously, airborne infections, can float throughout a room without ventilation for extended periods of time. This includes influenza, tuberculosis, SARS, and adenovirus. Although large droplet infections, such as the common cold, spread in a more limited area, in a person walking up and down the aisle of an airline, coughing and sneezing, this patient has the potential for infecting many others. A study was done during the SARS epidemic, examining 172 patients with fever and cough from SARS area. 67 of these patients were found to be infected with some disease agent that potentially could be easily transmitted. This includes 14% of the patients who had influenza, 15% who had parainfluenza, and 4% who had adenovirus. While these numbers might appear small, if you multiply the number of people that were exposed both in the airplanes as well as at transit points, potentially thousands of people could be infected from one source patient. Now let's return back to the emergency department, where both patients from home as well as traveling patients may present for care. In the setting of the emergency department, I'd like to review a number of diagnostic challenges that we face every day. This includes sepsis, influenza, pneumonia, tuberculosis, skin infections, meningitis, diarrhea, HIV and hepatitis C, and ENT infections. I've already alluded to sepsis as a major problem where time is of the essence and a delay in therapy may result in a poor outcome. This has been well documented throughout the literature. Over the past several years, much concern has been raised regarding influenza as a potential pandemic agent. This picture depicts a hospital ward from the 1918 flu pandemic that caused disease and death throughout the world. As recent as April and May 2009, when a strain of virulent and aggressive influenza was discovered in Mexico, served to remind us that the world may someday face another 1918 epidemic. Typical human influenza involves a number of common subtypes. The three major strains of influenza that infect humans include H1N1, H2N3, and H3N2. The vaccine that is administered every year includes the H1N1 and H3N2 types. H2N3 has not been included in a vaccine in many years. In addition, influenza B is included in the vaccine. Of concern is bird flu, which has infected millions of birds throughout the world. It is an H5N1 strain and has the potential to infect humans. We cannot, at the present time, identify these strains within the emergency department. We do rely upon data from the CDC, as shown in this slide. Each year, in late January or early February, there is a spike in influenza cases, and the types of influenzas are identified. In the emergency department, we empirically may diagnose somebody with influenza based solely on data from public health sources, which may be incorrect. It is important to know which influenza strains are infecting persons in order to select the right antiviral agent. As an example, resistance to oseltamivir was minimal during the 2007-08 year, with 10% resistance. However, in the fall of 2008, most strains were found to be resistant. In fact, 98% of strains circulating in the United States at that time. However, amantadine was effective for those circulating strains. Knowledge of the type of influenza that a patient presents with in the emergency department is critical in order to make the appropriate choice of antiviral agent. This is more than just academic interest. Patients may sustain complications of influenza, including an influenza pneumonia or a secondary bacterial infection. Many bacterial infections are from Staphylococcus, and aggressive and devastating pneumonia. Treating influenza early will decrease the likelihood of patients developing complications of influenza. And now a few words on avian influenza. Human cases have largely been confined to villagers who have extensive contact with birds in Southeast Asia. However, there is concern that mixing of influenza strains or mutation may make the H5 strain readily infective to humans. It would be extraordinarily important to be able to diagnose this up front in the emergency department setting. Many experts believe that the worldwide panic that occurred after the discovery of the Mexican variant influenza virus in April of 2009 is not the last time we will have an influenza scare or a potential pandemic. As illustrated here, influenza virus contains 7 strands of DNA which easily can intermix in patients, birds, or pigs, which are co-infected with different types of virus and potentially creating a more virulent organism, period. Patients may then become ill and present undifferentiated to the emergency department with only fever, cough, and weakness. And now an update on the 2009 H1N1. In the spring, an unusual spike in influenza was detected by the CDC. Look at this schematic here. The black line represents the percentage of positives, which normally decreases at the end of flu season, in this case, week 13 and 14. Beginning of week 16 and 17, there was a sharp spike in percentage of positive influenza test for those patients who presented with influenza-like illness to Sentinel providers. Even more dynamic are the type of influenza as it's shown here. The orange bars are the novel H1N1 for 2009. The yellow is subtyping not performed, which in many cases is presumed also to be the 2009 H1N1. In a normal season, late spring and summer see very little influenza activity, that is weeks 19 through 30. During 2009, a peak is seen about July 1st. This is alarming for several reasons. First, it indicates an unusual virus strain, for it is rare to see summer peaks in influenza virus in the northern hemisphere. Factors other than the virus may have contributed to this. Of great concern, though, is that this spring, early summer spike was also seen in the 1918 influenza outbreak worldwide. Normally, weeks 16 through 30 would be flat, and in this unusual year, the CDC had to continue its chart onto a second page, as shown here, which brings us into October, showing a rising percent of positive influenza test, as well as a large percentage being typed as the novel H1N1 influenza. Again, I would like to point out that the yellow bar is non-typed influenza, which presumably is the H1N1. Thus, the vast majority, in fact, over 95% of circulating influenza is the novel H1N1 in this country. H1N1 is referred to by a number of names, including pandemic H1N1, 2009 influenza H1N1, swine flu, Mexican flu, or California, or A California 07209 H1N1. So how does 2009 pandemic H1N1 differ from seasonal H1N1? And as you recall, most seasonal influenza is caused by less virulent strains of H1N1 or by H2N3 varieties of influenza A. As shown here, pandemic H1N1 creates a greater risk in younger age groups. It has a higher incidence of respiratory failure associated with it, and many patients have GI symptoms, primarily diarrhea. In some cities, as many as 30 to 40% of persons with diagnosed influenza actually have diarrhea. Overall, this disease is more severe than the seasonal influenza that we have experienced over the past 20 years. In addition, the illness lasts longer. As you recall, seasonal influenza caused by H1N1 affected primarily older groups and was mild in many other persons. H1N1 has increased morbidity over seasonal flu. The illness is longer. It may last over 14 days. There is a prolonged post-illness recovery period. Patients may miss work for extended periods of time, and employers need to be sympathetic to this. Increased hospitalizations have been documented, and obviously this 2009 H1N1 has had a significant impact on the workplace. So why are more hospitalizations and deaths occurring with 2009 H1N1? First of all, there's a higher incidence of primary influenza pneumonia. Secondly, there's increased death of respiratory cell tract tissues at multiple levels throughout the respiratory tract. In the past, many seasonal flus have affected primarily the upper levels of the respiratory tract, whereas the 2009 H1N1 can affect all levels down to the alveoli. Thus, there's a higher incidence of respiratory failure and ARDS requiring respiratory support, and these are similar to what occurred during the 1918 pandemic. This chart shows the age distribution of deaths from influenza H1N1 of approximately 300 persons between August 30th and October 10th. I want to call your attention to the two green portions of this chart. The darker green are deaths of 5 to 18-year-old persons. This is highly unusual that so many children would die from H1N1. Additionally, the light green, which is the age 25 through 49 age group, shares 32% of the deaths. Now, in contrast, the vast majority of deaths from seasonal influenza would be in the 65 age group and older, which for this epidemic represents only 12%. So why are younger persons at risk for pandemic H1N1? We don't know for sure, but several studies have suggested that prior exposure to influenza or influenza vaccines give a partial protective effect. In this study by Hancock, published in the New England Journal in September, 4% of persons less than age 30 had protective titers of greater than 1 to 40. In contrast, 34% of persons 60 years or older had protective titers, and even stronger titers. These 34% had titers of 1 to 80 or greater. So let's summarize why pandemic H1N1 is more severe than seasonal H1N1. First of all, there's been a major antigen shift in the hemagglutinin antigen, which is what sticks to our cells prior to absorption by the cell. Secondly, the virus replication occurs extensively throughout the respiratory tract, as previously mentioned. There are more release of toxin, and it's believed that there is greater shedding by infected persons. Let's take another look at a schematic of the influenza viron. The major surface antigens are the hemagglutinin and the neuraminidase. In the case of the novel H1N1 influenza virus for 209, both of these antigens are derived from swine origin. In fact, this is called a triple reassortment virus, as the 8 independent genes within the viron are a mixture of swine, avian, and human. Let's look at this in the context of the pathogenesis of influenza. Normally, the virus would stick to the upper respiratory cells. In this case, the swine hemagglutinin is quite effective in sticking to humans. It penetrates into these cells, it replicates, it synthesizes toxins, it releases itself from the cell and infects additional cells. And after its cellular release, the cell dies. Of the 8 influenza genes for the 209 H1N1, 5 are derived from swine origin. In fact, some of the most critical genes, as depicted here. 2 are avian, and 1 is from human origin. So what medications are available to combat H1N1? The most talked about is oseltamivir, but its effectiveness depends upon the type. As we experienced in the 2008-09 season, nearly all the H1N1 isolates tested were resistant to oseltamivir. It was almost a surprise then to find that pandemic 209 H1N1 was sensitive to oseltamivir, although isolated reports of new resistance have recently been reported. It should be remembered, though, that oseltamivir has only been shown to decrease symptoms if begun within 48 hours. There are no studies on preventing pneumonia or ARDS in pandemic H1N1 with oseltamivir, although it has been used for this. In addition, there are no studies as yet published that show mortality prevention with the novel H1N1 for 209. Zanamivir is another antiviral agent which has been found to be effective against influenza A. As of mid-October 2009, zanamivir was effective both against seasonal H1N1, 209 H1N1, influenza B, as well as influenza A H3N2. Zanamivir must be administered through the inhalation route. So why is a special vaccine needed for pandemic 209 H1N1? 209 H1N1 has unique antigenic characteristics. The special 209 H1N1 vaccine will contain A California 07/209 H1N1. This is antigenetically different than the H1N1 contained within the trivalent seasonal vaccine, which is A Brisbane 59-2007. Some studies have suggested that there may be some partial protection provided by the seasonal vaccine against H1N1. However, public health officials feel that this will be insufficient to protect the population and are therefore recommending the H1N1 209 pandemic vaccine to high-risk groups. New requirements require hospitals and emergency departments to identify and treat patients with pneumonia early. Patients need to receive antibiotics within 6 hours of presentation to the hospital. This is a challenge to many emergency departments that are overcrowded and have no empty examining rooms. Some emergency departments, therefore, will try to identify patients with potential fever and cough and send them directly to X-ray from triage, only to have the patient return either to the waiting room or a crowded hallway. Patients may then receive antibiotics for the pneumonia. In some cases, patients do not have pneumonia and receive antibiotics inappropriately. This problem was revealed in a recent study published from the University of Connecticut. In this study, of 86 patients who were discharged with a diagnosis, it was found that 22% had atypical presentations of pneumonia, including weakness, altered mental status, and abdominal pain without fever and cough. A thorough analysis done by the researchers showed that achieving the early antibiotic goal in 95% or more patients would result in inappropriate antibiotic use. If we are able to specifically identify a pathogen through nasal swabs, sputum, or other means, we could more appropriately diagnose and treat pneumonia. This problem is highlighted by the increase in staphylococcal pneumonia. A recent study reviewed 100 patients who were children that had staphylococcal pneumonia. In that study, 76% had MRSA, and aggressive pneumonia resistant to multiple antibiotics. Being able to accurately diagnose MRSA upfront in the emergency department would improve patient outcomes. 30 years ago, it had been predicted that tuberculosis would soon be a disease that would be rare and limited in the world. Unfortunately, this prediction has not become true, and indeed, tuberculosis cases have increased in the world. This is an X-ray showing typical tuberculosis in a cavitary pattern in the left lung. Patients may present with atypical symptoms of tuberculosis and wait in the waiting room for extended periods of time before an X-ray is taken and a diagnosis is made, as can be done with a X-ray showing typical tuberculosis pathology. To review, tuberculosis is airborne for hours. The first immune response involves macrophages and interleukins. The cellular immunity of tuberculosis is complex and not fully understood. A vaccine other than BCG used in underdeveloped countries of the world has been elusive. The current diagnostic techniques rely on culture of tuberculosis, which may take weeks. A new test called a quantiferin test is available, but this only shows if the patient has been previously exposed and does not help to determine the acuity of the illness. In some countries, patients with different strains of tuberculosis are mixed in a single ward for treatment. This often leads to intermixing of the tuberculosis strains and development of resistance patterns. Indeed, over the past several years, multi-resistant tuberculosis, which is resistance to INH and rifampin, has increased. In 2004, 4% of tuberculosis cases overall were multi-drug resistant. It is estimated in 2009 that approximately 10% are resistant. This map depicts the distribution of multi-drug resistant tuberculosis throughout the world. And while Western countries currently do not have a large burden, it is a mere airline trip of 24 hours or less that can bring a patient with active tuberculosis that is multi-drug resistant into Western Europe or the United States, which indeed has been documented to have occurred. Extensively resistant tuberculosis called XDR-TB has recently been described. This is a MDR-TB that has additional resistance factors as formally defined to one or more quinolones and one of 3 injectable anti-tuberculosis drugs such as amikacin. Travelers from endemic areas, foreign-born, patients with previously treated tuberculosis within the family are at risk and potentially may infect both staff in the emergency department as well as patients with this very dangerous strain of tuberculosis. The seriousness of the tuberculosis burden throughout the world cannot be overestimated. A major step towards reducing the tuberculosis burden is rapid identification of and segregation of patients with tuberculosis. Now let's move on to skin and soft tissue infections. I'd like to first describe a case. This is a case of an 18-year-old male who presented to the emergency department with fever, altered mental status, knee and thigh pain, period. The patient states he contused his right thigh 3 weeks prior to presenting to the emergency department. On examination, his thigh was red, tender, and had warmth, and he had decreased motion of his quadriceps muscles. Laboratories revealed a C-reactive protein of 24 and an elevated white count. An MRI showed myositis and soft tissue infection, and cultures revealed that this infection is MRSA. Most patients who are seen in the emergency department have community-acquired MRSA. This is obtained through close contact, and many times in schools, in athletic facilities, and is also seen in prison guards and jails. Direct contact can be from chairs, countertops, skin to skin, or other surfaces. Many infections start from minor abrasions or contusions, and it has been established that MRSA is aggressive and creates a challenge when choosing the appropriate antibiotic. Some MRSA infections present as abscesses or a combination of abscess cellulitis, which are initially IND'd in the emergency department. If only we had a means of identifying whether this was MRSA or other staphylococcus or strep, we would be able to choose an appropriate antibiotic. The problem with MRSA has been highlighted by recent legislation within California. California state law now requires testing and reporting of all patients who present to the hospital and are hospitalized in the ICU, undergo surgery, or are patients requiring dialysis or patients admitted from skilled nursing facilities. Current testing of these patients is laborious and requires plating onto special auger and incubation. The diagnosis may not be available for 48 hours, by which time patients with MRSA in hospital settings may have exposed other patients and staff. Now let's turn to meningitis. Meningitis may not always present straightforward. In this case, a 38-year-old male presented to an emergency department at 9 o'clock in the morning. The patient was acting somewhat confused, as described by the patient's wife. However, the patient's problem was not identified as serious, and therefore the patient waited throughout most of the day before being seen by a physician in the emergency department. Once the physician saw the patient, a lumbar puncture was done which showed white cells, and the patient was given empiric antibiotics. Empiric antibiotics for meningitis include ceftriaxone, vancomycin, and in old or debilitated patients the addition of ampicillin. Decadron is also recommended currently. However, in this case described, the patient had herpes simplex virus encephalitis. This requires treatment with acyclovir. Aggressive early treatment with acyclovir can be life-saving and prevent morbidity. Means of rapid diagnosis of HSV would benefit patients in the emergency department setting. Diarrhea is a common disorder that presents to the emergency department or acute care settings. The etiologic agents causing diarrhea are many. A few are listed here, including viruses, certain subtypes of E. coli, Salmonella, Campylobacter, Shigella, cholera, Giardia, or Clostridia difficile. Some of these do not require treatment in the emergency department. Others require specific treatment. If the etiologic agent can be identified, goal-directed therapy can be initiated and improve patient outcomes. Unexpected infections do present to the emergency department. Most recently, an outbreak of Salmonella occurred in the United States as a result of contaminated peanut butter products. Many patients with Salmonella were not initially diagnosed because of limited diagnostic capabilities in the emergency department setting. If technology existed to identify pathogens in all patients with diarrhea, outbreaks of Salmonella, Campylobacter, or specific strains of E. coli can be more readily identified. Over the past 30 years, HIV and the full-blown form of AIDS has enveloped the world. In the United States, most patients are treated in specialty clinics. However, when a patient becomes ill, they are referred to the emergency department by their physician or come on their own accord, period. Many infections that they have are opportunistic and may progress rapidly. Current therapy is empiric and generally involves a shotgun approach, which may complicate care of the patient. Having specific diagnostic capabilities and pathogen and the ability to identify pathogens in the emergency department will improve HIV care. Hepatitis C is a major concern in the emergency department. In busy urban emergency departments, each physician sees 2 to 3 cases per shift of identified hepatitis C. In addition, there are another 2 or 3 patients which are unidentified. Only 15% of patients with hepatitis C have an acute episode. Most patients have a latent period of 10 to 20 years. In California, a huge burden of hepatitis C exists in the prison population. Although transmission is primarily intravenous drug use and blood exposure, data is now appearing suggesting that sexual exposure may also be a means of transmission for hepatitis C. Hepatitis C is highly contagious from a needle stick point of view. At present, no vaccine exists to hepatitis C in contrast to hepatitis A or B. Healthcare providers, including physicians, nurses, and phlebotomists, are at risk from undiagnosed patients, and some healthcare providers may inadvertently be exposed to blood products. Easy identification of hepatitis C would assist in identifying patients who may have placed emergency department staff at risk. Current trials are ongoing for appropriate treatment, prophylaxis of those patients exposed to hepatitis C blood. ENT infections are another example of time-dependent infections in the emergency department. Our concern is airway closure and compromise. This child has a broad differential diagnosis, including everything from cellulitis to cat scratch fever to mumps to ear infections to pharyngeal abscesses. Culturing of the tonsillar and pharynx areas takes time, and rapid identification of pathogens involved in pharyngeal infections is important. I would now like to review some of the traditional diagnostic tools used in the emergency department in the case of infectious diseases. This includes blood cultures, which generally take 1 to 3 days to be reported as positive, but in some cases as long as 30 days in slow-growing organisms such as Bartonella. Sputum cultures are taken less now in the emergency department because of problems with cross-contamination. In days in the past, gram stains were actually done in emergency departments. Urine is sent for culture, but may take several days to return the name of a pathogen. CSF cultures are sent, as well as cultures of cavitary fluid such as peritoneal fluid or fluid obtained from a thoracentesis. Stool cultures are available, as well as examination for ova and parasites, and viral cultures, even if done as the shell method, may take several days. Fungal cultures take weeks. Our menu of rapid diagnostic testing in the emergency department setting is limited. Rapid flu test and rapid strep test are available in most emergency departments. Although a test for urine antigen for pneumococcus exists, it is not widely used in emergency departments. Some hospitals can test CSF fluid for antigens within hours after a lumbar puncture is done to assist with more specific diagnoses. Improving emergency department care of infected patients actually begins at triage. The triage nurse potentially could identify those patients with fever and cough or nonspecific symptoms and take a nasal swab of those patients suspected of having a respiratory pathogen. If this could be processed in an adjacent PCR analyzer, it would allow for the early identification of patients who have potential highly infectious respiratory diseases and prevent the spread of the disease to others. In addition, it would allow for early treatment. If patients are not recognized as being at risk for illness at triage, they certainly undergo a secondary screening when they have a full exam by a physician. Samples of blood or body fluids can be taken by the physician or nursing staff once the patient is in a regular examining room and sent to the adjacent point of care testing for more immediate identification of potential pathogens. Prototypes of rapid analyzers have been developed. The distribution of these, once refined to emergency departments as well as acute care centers, will revolutionize the way medical care is delivered in emergency departments and treatment is administered. To review, at the present time, many respiratory pathogens, including influenza, RSV, adenovirus, tuberculosis, Legionella, and MRSA, may be spread throughout the emergency department. You may say, put a mask on the patient, and masks are put on patients during specific potential pandemic scares. However, patients do not always wear masks, and the sheer volume of patients prohibits isolation of each one of them for extended periods of hours. Rapid testing would limit the amount of time they need to be isolated until a final pathogen has been identified. Pathogens from blood, bodily fluids, urine, abscesses, and diarrhea, such as E. coli, meningitis, MRSA, MSSA, streptococcus, pneumococcus, Klebsiella, herpes viruses, and anaerobic infections could be identified rapidly with new point-of-care testing and therapy initiated immediately. To summarize, goal-directed therapy, once pathogens have been identified, will improve outcomes. The ability to transfer patients more rapidly out of the emergency department to specific care areas in the hospital will be improved. In other words, patients do not need to sit in the emergency department for 12 hours undergoing extensive testing to determine what type of infection they have. Isolation of patients with certain diseases can occur rapidly, and this will result in the safety and protection of healthcare workers. In closing, I'll repeat that emergency departments are the portal of entry for many patients with acute infections, and rapid identification of pathogens will revolutionize care in emergency department settings.